Please keep in mind to share any hints that you get from this with anyone else who's not here today, since we made a bad choice in choosing which day to do this for other schedules, and we will post the slides. But I will turn it over to Sheila and Stephanie.
I think, is my screen being shared?
Yep, it looks good.
Great. Thank you so much. Thanks for having us today. I'm gonna do the driving of the slides. We're going to talk a little bit about clinical operation updates, safety and patient experience benchmarks, core quality metric performance, best practices for continued success, and future initiatives. So just some key reminders, and some of this is repeat, but I think it's always helpful to hear it more than once. And please chime in if you have any ideas. But I just wanted to remind people that there are 4 new CMAs in clinic. So it's Day, Kenya, Lindsay, and Kendra. So there may be some things that they still don't understand how to do. So, be patient. And welcoming to them, and just know that they are learning, and I appreciate your patience with that. Dee DeShera is now the Maryland PCP coordinator CMA, so she is sharing an office with Stephanie. Kamala can now do fiber scans. She's been certified to be able to do fiber scans. And the next person that we're going to train in that is Lindsay. And that all the CMAs, rather than having a place where each of them sits, they're all going to be rotating to different zones based on the volumes and the needs of that day or that week. So you're going to see everybody's face in different zones in the clinic, and they should all be able to provide you with the support that you need to see patients in the clinic. So please always let me and Stephanie know if there's anything that we could help the CMAs improve upon, or any help that we can give. So I appreciate your patience as we have new people up and running. Just again, the reminder about vaccinations and medication administrations. The CMAs must document at the time of administration. They can't come in, put the shot in somebody's arm, and then go out and document. They have to document at the time of administration. That is the only safe way to administer medications. Rooming patients does take time. So there's about 15 steps to rooming patients. So please understand that it does take a little bit of time for the CMAs to room patients, so allow them adequate time to do that. If an exam room is not available and you're running behind, CMAs will have patients wait in the waiting room for then you to be able to go out and greet the patient. I'm going to stop there. Any questions, any comments? I'm going to move on to team communication. Please use secure chat for assistance. If you don't see a CMA in the workstation, do know that when you put in an order, it turns a dot blue in the schedule, and the CMAs know that that means that you need something as far as an immunization or an injection. And then also use secure chat to communicate when you're running behind, or if you're able to see somebody early and that you would like them to let the patient know that you're running behind, or if you're able to see the patient early, and the CMAs will do that. Please secure chat in the Bartlett CMA group. Again, I always encourage this, check in with CMAs at the beginning of each of your sessions to communicate anticipated patient needs or clinic needs. This is still on the list this month. The Joint Commission is coming. We are in the window between now and the end of December. So just make sure that you remove all your personal belongings from the exam room each day, and make sure that there's no confidential information left in the exam rooms. Also, let the CMAs know if there's any needs in the exam rooms. They are supposed to be checking for supplies on a weekly basis. So if you don't have things, please let them know. And I guess I'd like to know if the exam rooms aren't being stocked regularly. And then we used to have all these jabber phones that people carried, and they really weren't ever used. But Secure Chat has kind of taken over for the jabber phones. So we're not using the jabber phones anymore. And then we just ask that providers check their Epic Daily for messages, and that when you have a clinic scheduled, that you're here during their clinic time, that you're in the clinic for your session and not elsewhere, that we have to find you. And that's it. I appreciate all those um reminders. Appreciate you listening to those reminders, and thank you for all that you do. We're going to go on, unless you have any questions, comments, concerns. So Stephanie's going to do the quality performance measures review.
Good morning, everybody. Good afternoon. It's afternoon now. Can you hear me okay?
Mm-hmm.
Perfect.
Yep,
All
you're
right,
great.
thank you. I'm going to start with reviewing our safety and patient experience. These, just so you guys know, these metrics are always posted in the back hallway where the restrooms are. We post them every month. I know that everybody doesn't have access to seeing these or know where to find them, so they're always in the back hallway. I wanted to start by sharing our patient experience. So for our chaperone policies, we're as of last month, April, the month before in April, we were compliant at 91%. Providers, you guys are doing a great job of closing encounters in 14 days. We're above target there. Our hand hygiene, we're above target at 99%. Our in-basket messages, we do a great job at communicating with our patients and responding back to them in a timely fashion. And then following up with them in 14 days on any of their test results, we're above target there. Some work to be done around patient ID. We are at 81% and the target is 90 or above. I'll talk more about that. There's a new question that goes out to the patients for their Press Ganey surveys, and it asks them, have we made efforts to identify them, asking them if they confirm their name or their date of birth prior to their test, treatment, or procedure. So patients are being asked that question and they are indicating no. For our patient experience scores, our overall provider rating is 92. Our patients love you guys. They recommend this office. They say that we are timely. Overall visit rating is in the green, above target at 89. You guys communicate well with patients. They're indicating that. The staff quality is 94. They think we're great. Telemedicine technology, they seem to be happy with being able to communicate with us via MyChart and having televisits. Our visit wait times are above target at 84%. And there is some indication that we need to show patients that we're working better together. I know Sheila and Abby had discussed this. Sheila, I don't know if you want to add, chime in on what you guys talked about in terms of initiatives to improve how we work well together and become a more cohesive team.
I just think again, if we know that there's going to be concerns with the patient coming in, or it's going to take longer to see a patient, that we discuss that, not out on the floor and not at the zones. Like the other day there was something going on with a delay in patient care, and I closed the door to the room instead of the patient hearing what was going on. So those kind of things, you just have to be aware of them. And because patients listen, they come in here and they're like ready to see their provider, and then they're hearing some of the stuff that's going on in the clinic, so they might think, oh, they're not really working very well together.
That's a great point. We do the best we can, and I think we do a great job, and things are not going to be perfect every day, but patients, they do listen, and they may, even though it's not a big deal to us, and this is just maybe a little mishap to them, it looks like we're not working well together. Okay, Shirley, you can go to the next slide. This best practice tip sheet should be in every room, and I believe we had it laminated. Just I know it might be silly. It's even silly for me sometimes. Like, we know our patients, some of you providers have been seeing patients for 15 plus years, but we have to ask, I know who you are. We can make a joke out of it. I make a joke out of it. I know who you are, but just in case you get this survey in the mail, can you tell me your name and date of birth? Because they are getting this question, and we're not at the target. So we have to be doing our patient identifiers. Can you tell me your name and date of birth? And that's all.
Stephanie, can I just ask, so how many times is that supposed to happen during the visit? Like, are we,
So they should be asking at check-in. The CMA should be asking when they call the patient back, and then the provider should ask. Now, I don't know when patients are getting this question, if they're answering no because of front desk or CMA or provider didn't ask. We don't know. We don't know who didn't ask, and we don't know what the patient is thinking when they answer this question. So they definitely should be asked when they come to the front. The CMA should be asking when they call patients back. I think where it's a little bit silly is when you bring your patient back and you know who your patient is, but we still should ask.
yeah, that sounds like weird. It's like,
It
hi,
is.
hi, Stephanie, can you please tell me your name?
I make a joke out of it. I'm like, hey, I know who you are, but I have to ask in case you get this survey in the mail. And they think it's funny. They just laugh and say, oh, my name is so-and-so, my date of birth is so-and-so. It's fine. Things we have to do. But mistakes do happen. We've had mistakes happen here with patients not being correctly identified. So I understand the purpose of it. Okay, so going into our core quality performance measures from April, I just want to always give you guys praise. Year after year, I don't care about the red, we have been making tremendous progress. 6 of our measures are outperforming last year. Breast cancer screening, colorectal screening, controlling our patients' high blood pressure, having our patients followed up on if they are have a history of depression, kidney health evaluation that has improved from last year, and patients who are diabetic without cardiovascular disease, they're on their statin therapies. We still need to do work, obviously. Breast cancer screenings, we are under target 73%. The goal is 80. Colorectal cancer screening, we want to have at least 76% of our patients compliant and having their colon cancer screenings done. We're at 66%. Our controlling high blood pressure, that has been a metric that our nurses have really been targeting on their administrative time to try to reach out to patients who had these blood pressures greater than 140/90, and have them come in for a follow-up or give us a patient-reported vital sign or see their provider if they haven't seen their provider. So that has actually gone up, and we're now at target for that. Depression screening follow-up, we've always been at target for that one. HbA1c control, so these are our patients who come into clinic who are diabetic and haven't hit an A1C in 3 months. We want them to get a point of care test, or, if the patient or you prefer as a provider for them to go to the lab, that just needs to be done. In terms of the kidney health evaluation, I saw last year that by the end of the year, this measure improved. And if I can recall correctly, we did meet the target goal. And this is just having our patients get that microalbumin test if they are a diabetic patient. So we did improve from last year to this year around the same time, but more work to be done there. And then for our well visits, we did take a little dip. We now have Dee in place as our MDPCP coordinator. She just started on Monday and she's already working really hard. I know some of you have gotten emails from her just to make sure that, the wellness visits are coded properly. And I know that it can be a challenge sometimes. So she's here. I'm training her. Both of us are willing to work with you guys in real time if you find that there's issues with the express lane or things of that nature. Okay. Any questions about that?
Just a comment, Steph, I think that we usually meet the hemoglobin A1C by the end of the year too.
We do. Yeah. When patients actually start coming in and making their visits, it gets done. And then these are just our paid performance measures. Cervical cancer screenings, we always do a good job at making sure our patients have those. Kudos to the GYN team for being here and helping us with that. Our diabetic blood pressure control. So our patients who are diabetic, they're looking to see that their blood pressure is controlled, and we are doing a great job with that. And then our diabetic eye exam, still room for improvement. I just want to remind everyone that's here that we do have a workflow that, as Dee gets acclimated in her role, she's going to try to work more with patients and providers patients who have not made it to Wilmer for whatever reason and are amenable to going over to Jayhawk, they are willing to allow us to use their IDX machine to screen patients for retinopathy, as long as they do not have a diagnosis of retinopathy. So that is a workflow that we have in place. We want to be able to utilize it more, of course, if the patients are willing and able to do so. And then statin therapy
Sorry,
in patients with,
Stephanie,
go
could you
ahead.
just go over that again? Because like I know for the mammograms, like there's like it has to be before 1:30 or like
Yeah.
what are the logistics around using that?
So I don't have the cutoff times handy right now, but the way that it works is, and I can send this to you guys. So I'll attach it at the end of the slide just so that it's something that's accessible easily from this slide.
3
Sheila,
p.m.
3 p.m. is a cutoff. Thank
Well,
you.
3 p.m., 3:30 the latest. So I think they are like be a little flexible.
Yeah.
I'm
They're a lot
looking
more
at it.
flexible than the same day mammograms. So what happens is if you want the patient to have it done, you would just indicate
Oh, I'm sorry. I was reading mammograms. Which one were you talking about?
the same day eye exam workflow. Do you have
Oh,
that handy?
I'll look for that. The
If not,
mammogram, it's 3:30.
that's for the end of the day. But Dr. Scully, essentially what you do, if the patient says that they will go over to Jayhawk and get it done, you would just send them the checkout, put it in your visit note, the wrap-up note, patient wants to go for same day eye exam, and they would just call over there and schedule it, and they can take them the same day. They also can take them on a different day, as opposed to the mammogram. They want the patients to be here at the same day. So if the patient says like, no, I can't do it today, but I'm coming to see social work tomorrow, I can do it tomorrow, they can also schedule them the next day as well.
Okay, great. That's helpful.
Okay. Any other questions about that? And if Sheila can't find it quickly, I'll circle back. I'll link it in this slide, the time frame. Oh, look at our MDPCP coordinator. She has it handy. So from 11 to 1, that's their lunchtime. And then
Yeah,
their cutoff time is 2 p.m. for the day.
why am I not finding that on our workflow?
But it's here.
Okay, good. Okay.
All right.
Thank you, Dee.
And then
But that like other day option is super helpful. Because like
yes,
sometimes people are like, I just need to leave for today, but I'll come back later. So that's great because that's not having that option for the mammogram is kind of a blocker.
yeah. All right. And then for statin therapy in our patients with cardiovascular disease, I just highlighted this one a bit because we're below target. And that it is metric of the month, and I'm be pulling the reports on this here just to see, follow up with providers and see if maybe it's a matter of not being appropriate for the patient. If that's the case, of course, if that's the medical provider's judgment, then that's understandable. But there are some codings, like if a patient had rhabdo, if a patient has myalgia, there's specific coding that should go in for those patients who may not be a candidate for statin therapy that would take them out of our denominator. And then you can go to the next slide, Sheila. And I just want to share with you guys our transitional care management measures. So Fatima is one of the nurses who works really hard on this. This is one of her roles, and she also has a full continuity panel as well. But she's done a great job with getting in contact with patients who have been discharged from ED visits or hospital admissions. I know when I came here a few years ago, this was something that I was doing, and it's not an easy feat. It's hard to reach out patients, and then you only have a certain period of time to get them on the phone and to get them in here in the clinic. So we've been highlighted at our previous meetings for how well she's been doing in actually reaching the patients within 7 days and 2 days, and our readmission rates have gone down tremendously. So if you can see, we're at 16.6, 16.1. The goal is 13, and you can see the trend of how we've done reducing those rates over the year. So it's evident, the data is showing that reaching patients, getting them in here for proper transition to care definitely does help reduce our readmission rate. And all of the other nurses, they do pitch in and help when Fatima is not here, when they're on the phone with patients as well. But I just wanted to give her a shout out because she does a really good job with that, and it's not an easy task.
Yeah,
Next.
this is great. These numbers used to be not good and they're wonderful. So when you see Fatima, please give her props for this.
You can go to the next slide, Sheila. This is just the information again, just the trend of how we've reduced our readmission rates. And then it shows you that 12% of our patients, the target is 13.5, 12% of our patients readmitted that had a 7-day follow-up. This was their rate. So we're doing a really good job here. And the same with the patients who were here for 14-day visits and 7-day visits. Now, the area where we have to do more work is getting the patients here. She gets the patients on the phone, she gets them scheduled, but as we all know, our patients sometimes don't show up. And so that's what we have to focus our efforts. Any questions? Next slide. All right, just going to go over some continued best
Sorry,
practices.
Sheila, it's Yuka.
Hi.
So I was wondering actually, is it possible maybe to use some of the donor money to get cabs, or like if we don't have that kind of money, or to send somebody out there just to see, like that might be a good place to use some of that estate money that we got donated.
So I think that we have money. There's still money to send lifts out. Sometimes it's getting a hold of the patient.
Or you get a hold of them and they still don't show up for the appointment.
Right. And they say, yeah, I'm coming, and then they don't come. So yeah, it's great to know that
Okay.
money's available. Thanks, Yuka. That's a good idea.
Okay, so just continued best practices, things that we're already doing, and we intend to try to continue and, make changes if we need to. So continue our outreach efforts that has been working really well over the last few months. One of the things that I do is send opportunity reports to nurses every month when we get this new data, and on their administrative time, they reach out to patients, educate them, send orders to providers if needed for mammograms, colonoscopies. Like I said, they do hypertension checks over the phone if patients have blood pressure cuffs at home. And it just helps to keep the patients engaged and kind of help us to have a more proactive approach as opposed to reactive. Care team meetings. I know some nurses and providers are able to do care team meetings. I do them with Julie and my social worker. They're really helpful to discuss our complex patients, people who are coming in or people who have come in the previous weeks that may have different issues that need to be addressed. And we talk about how we can handle it as a group. And so if you have not had these meetings established, maybe you should talk to your nurse to consider implementing them. And it helps to enhance our care coordination and collaboration. I talked about the same day workflows. So with outpatients it could be a challenge to have them get things done once they leave the door. So we want to try to optimize the same day workflows as much as possible. I know that they are not without barriers, like Dr. Scully just said, the cutoff times can be difficult. But if patients are here and they're willing to go to get a mammogram done at JHOC, let's, optimize that. Same thing with the IDX workflow. Once Dee gets acclimated, she's going to be helping and talking to patients and talking to providers and trying to make sure that is happening and it's smooth sailing. Blood pressure management, just make sure that your patients who have blood pressures out the door of greater than 140/90, they have to have a follow-up in 6 weeks. It doesn't have to be with you. You can send your nurse a message and say, hey, I gave them a blood pressure cuff today. Can you follow up with them in a couple of weeks? Or if they are MyChart savvy, we can enter a MyChart flow sheet and the patients can enter those readings into the chart on their own and they sync to their record. If a patient has a complex medication regimen or some resistance to their medication, they can see Kristen for a PharmD appointment, and all of these things would show that we are following our patients with hypertension. Okay, next slide. Annual wellness visit. We're going to continue to do what we've been doing, having the visits flipped proactively. If you have your patient in front of you and you're not able to do it for whatever reason, that is fine. We understand. We just ask because one of the things, this is an internal process and we're trying to make it more standardized at some point, but it is still internal. D and I are flipping the visits in advance, and we're going back and looking to see if they were done. So if you're not able to do it because the patient was late, or they just, the acuity was too high, or the patient said no, that is fine. Just please put in your wrap-up note for them to be scheduled at checkout for a subsequent visit. That's an annual checkup. And then it's also, I found it helpful for reconciliation purposes. Some providers will say, wellness visit due but not done today for whatever reason. That helps us to know, okay, this wasn't done. And if it wasn't scheduled, we'll reach out and get the patient rescheduled. And again, if you have any questions about the express lane or billing, we're here to support you. We know things are not perfect, and sometimes functionalities don't work right, or maybe it could be better. But let us know whatever your concerns are. And we talked about the transition to care management. Kristen Kilcrease agreed a few months ago, and I'm not sure that we've been utilizing her as much as I thought that we would. For patients who are discharged from inpatient stays and they have lots of medication changes or, a complex regimen, she's willing to see patients for a med reconciliation visit. So that might be helpful for patients with, transition to care management appointments if you need a more detailed reconciliation. She's agreed to see those patients. Fatima is aware, but I want to make you guys aware as well. And we're just going to continue to have conversations about how to continue to reduce our readmission rates and redefine workflows and do more with our patients who are high utilizers or high risk. Maybe some more intensive follow-up for those patients. Colorectal cancer screening, Nina, who is our early intervention services nurse, she continued to, work on our patients who need these colonoscopies. She outreaches them. She helps them get scheduled. She assesses any barriers they may have. She educates them on the prep. We also have clear liquids in the clinic that for patients who have food instability and may not be able to go out and purchase jellos and broths, we have some in the clinic. So I want you guys to know that as well. Patients who need escort, transport, we can coordinate all of those things with social work and with our navigators. For patients who've needed those services, it's been really helpful, and patients have been able to successfully complete their colonoscopies with that additional support. And then for patients who need Cologuard and they just haven't gotten it, we have 2 demo kits here for patients who just don't know how to do it or may need some education. The nurses can help with that, or now that once Dee gets settled, she can help with that as well. Next slide, Sheila. Any questions? No? Okay, and just wanted to share some future initiatives with you. We are working really hard, Sheila and I, on getting some NEPOs approved at the Bartlett. We've talked about creating signage in restrooms for patients for the urine microalbumin, because sometimes I see that the providers, you guys are ordering it, and patients might go to the lab and get their blood work, but they're not leaving the urine. So maybe they're voiding before their visits, and then they can't go after the visit. So we've talked about getting some signage in the bathrooms for patients to say, hey, if you need to use the restroom before your visit, ask for a cup. We just have to operationalize that, of course. Our MD-PCPC in May, Dee, she's going to be signing well visit questionnaires to patients ahead of their visits. If they use MyChart, that can cut down on rooming time. Those are some things that we've been talking about. Outreaching patients with standing Cologuard orders, like I just discussed. And like I said, more discussion around following up on our high utilizers. And just want to remind you guys that the work that we do with these MD-PCP metrics and HEDIS measures supports the quadruple aim framework, right? So our goal as healthcare professionals is always to improve preventative care and to enhance our population's health. We want to make innovative improvements, iterative improvements to be able to streamline workflows, to improve our patient experience and reduce their care gaps, to keep them healthier. And we want to be able to lower healthcare costs. And we do this by keeping our patients healthy, keeping them engaged, keeping them out of the hospital. And finally, I like to involve you all. And the reason why we share this information is we want you guys to give us feedback in processes and things that we need to change, and want to be able to give you guys the tools to succeed. And that overall will support your well-being. And that's all I have for you guys. Any questions, concerns, comments? I'm always here.
Yeah, I will just jump right in to say, Stephanie, thank you so much for always turning discussion of metrics into actual meaningful information about clinical care, and even including our wellness in your scope of work. I am so thankful for your leadership in the clinic around this, and I know that our patients benefit from it all the time.
Thank you.
Thanks, everybody.
Any other questions from the group while I just pull up our case slides for today?